What are the things I've got to have in the back of my mind, preferably before I did the thrust, so I can justify myself?
Well, you've got normally 2 years before you get there, but it gives you lots of time to prepare for this.
Yeah.
And you've got to have the right queries, because you're expert in what you do. You're not expert in what he does, and he's very good at being very difficult. And I say, firstly, it relieves pain. And we know that. And he can say, well, you've increased the pain, therefore it hasn't worked. So I can say, well, you also do it to increase movement. After the thrust, you instantly got more flexibility. You can also do it because circulation increases. You see the tissues get red after the thrust.
Yeah. Can I just take you back to the movement, though? Hasn't it been argued by people that rather like doing MET, the movement increases immediately afterwards, but does that increase stay after that, or does it revert?
If you've got the condition and you made change to the way the tissues behave, it does, and it gets better. If you haven't got them right, it comes back to where it was, which is interesting. And when the patient comes back, if they're not better, it's no good. It's not going to work.
Yeah. You're in the middle of your list, but I've just seen a comment come in from Joanna at Cram Osteopaths in Glasgow. They're a brilliant bunch at Cram Osteopaths. I think they've won awards for their practice and so on. But they say that they now do 15-minute lists, efficient and effective treatment, and a thriving list, not to mention manipulation is so much fun. And it is. It can be. Yeah. So, Joanna, thank you for that. I don't know which camera I'm on, but great to hear from you. Right, so where do we get to? We've got it relieves pain, it increases movement,
and it will change the neurophysiology. Patients got tingling in the hand, and you pop the neck, and they say, oh, that's better. And instantly it goes. There can't be nerve pressure because that takes time. Maybe it's relieving pressure, but you're changing the way the nerves function. And you can see that in people, that happens. And that they can't argue because they don't know much about that. You can use it to break fixation. Somebody goes to turn, the neck won't go, and you apply a very gentle thrust, and immediately the movement comes back.
I was having this discussion with, we did a broadcast a few days ago with Ian McDermott, who's a knee consultant orthopod in London, and he's actually buggered his back up. And it was quite, it was fascinating because he came on the show and it was clear that he's an orthopedic consultant, but he knows very, very little about the spine. And he said, I couldn't look at an MRI of a spine, we could look at knee MRIs all day long. And he was saying, well, what's the say? Can you sublux a joint in the spine? And I hate answering that question because I don't think anyone's ever proved what it is that causes the restriction. What would you say?
When I was a student, we learned either it's flexed or extended, it's side bent or rotated, or combinations of that. And a lot of colleges still teach that. I don't know, maybe they do that here. But when you're looking at something, which way has it gone? I daren't thrust it because I might be wrong. And nobody's around, give it a little push. Oh, that's better. And the longer I go on, the less I'm concerned about which direction it's gone. The thrust is to open that joint, and that's it. And in the occiput, as you'll see later, we've got somebody with an occiput problem. It doesn't matter which way it's gone. If you